The recording will be posted on the committee's webpage after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. As a reminder for everyone, please remember to use the primary care committee email box to send updates or questions. And if you are not a member of the committee, please turn your camera off now. I'll turn it over to Chair Dr. Judy Zerzenthul to call the meeting to order.
Great, thank you. It looks like we have most people, is that right? So
It
I'm
does look like that.
scrolling through screens. So good afternoon and welcome committee members. It's now 2:03 p.m. and I call the January 23rd meeting of the Advisory Committee on Primary Care to order. Thank you all for joining us. I'm going to start with an overview of the agenda, which begins with roll call. After roll call, we'll vote to approve the meeting summary of the November committee meeting. Then we'll open the floor for public comment. Next, Kaylee and Hannah from HCA will present on Making Care Primary update. Then there will be an overview of the policy and strategies we'll be exploring in more depth in the coming few months to reach the 12% primary care expenditure target. I encourage committee members to ask questions and provide feedback. And then there will be two presentations about primary care workforce. And then we'll talk about that in the next meeting. So thank you all for your time and effort. So roll call, I'll call on members by first name in the order listed on the agenda, which is alphabetical by last name. And when I call on you, please unmute your microphone, maybe turn on your camera and let us know that you're here and then go on mute again. So Crystal. Sharon Brown.
Here.
Thanks. Tony. Michelle.
Hi, I'm here.
Perfect. Tracy. David. DC.
Hi, here.
Thanks. The second Sharon.
I'm here.
Thanks. Gregory.
I am here.
Perfect. Chandra.
I am here.
Thanks. Meg. Cheryl.
Hey, I'm here.
Thank you. Lon.
Hello, I'm here.
Thanks. Katina.
Good afternoon, I'm here.
Excellent. Mandy.
I'm here.
Thanks. Jonathan.
I am here.
Perfect. Sarah. Linda. Sean.
Here.
Thank you. Stacy. Ginny.
Well, I believe he's being admitted.
Oh, okay. And Maddie.
I am here.
Excellent. So now I'm going to turn it back over to Mandy, who will facilitate review of the November meeting summary.
Thank you, Judy. Please join me in turning to the meeting summary in the meeting materials. The recording of the last meeting is posted on our webpage. Is there any discussion of the meeting summary or any proposed changes?
Yeah, hey, it's Cheryl Morelli. I believe I was at the meeting, just not at the beginning during roll call. I have it on my calendar and I'm usually pretty good about deleting it if I didn't attend.
All right, we can make that change.
Thank you. Nothing else.
All right, with that change, is there a motion to make that change or a motion to accept the meeting summary with that additional change?
So moved. I second.
Any discussion of the proposal? All in favor? Say aye.
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 Any opposed? All right, we will, that motion is accepted and meeting summary is approved. Next, we'll open to the floor to public comments. If a member of the public wishes to make public comments, please raise your hand. When you are called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps ensure that everybody has an opportunity to speak. We also welcome anyone to provide public comments in writing by email at any time. Please remember that this is the time for public comments, and Q&A sessions during the meetings are reserved for committee members to ask questions. I'll turn now to see if anyone has their hand raised. See anyone with their hand raised, but we'll give it another minute since the time period for opening public comments begins at 2:10, and I don't want to close it before that opportunity. So we'll just give it one more minute for anybody to raise their hands.
And I don't know if you can see the chat, but Tracy is here for the roll call. I don't know if anyone else has joined.
I did see that. Thank you. Probably another 30 seconds. Anybody would like to make any public comments? We'll go ahead and close the meeting for public comments. Next, I would like to welcome Kaylee Dufresne, Special Assistant for the Health Policy and Programs at the Healthcare Authority, who will provide an update on Making Care Primary.
Thanks, Mandy. Can you hear me okay?
You sound great. Thank you.
Thank you. All right, you can flow ahead to the next slide. Awesome. All right, so a couple of months ago, or months, I don't know, time is irrelevant. A couple of meetings ago, I came and shared with you all an update about the Center for Medicare and Medicaid Innovation is testing a new primary care model in 8 states. Washington was selected as one of those states. This model has a 10.5-year time period. It's intended for primary care practices to progress in their capacity and really advance in both integrating care and offering more advanced primary care services and supports, and steadily integrating more with some specialty care over time. And it does that through this progressive payment model structure, which I shared, and towards trying to get multiple types of payers to align to similar types of payment principles to ease provider administrative burden, so that they're really just focused in on similar types of payment models across all of their different patient populations. So Medicare's portion of this model, which again is the Medicare fee-for-service or traditional Medicare, is where they're testing this model directly. Providers had the opportunity to apply to participate. Those applications were due in the middle of December. So we wanted to share the good news, we think, about how those applicants shook out in the state. We have 44 applicants representing 437 sites. We had great representation of both urban and rural practices, even though rural health clinics are not eligible for the Medicare portion of the demonstration model. We did have some providers that are in more rural zip codes, rural areas apply to participate. About half of the applicants are federally qualified health centers. There are, as we talked about in our conversation, some additional supports and incentives for FQHCs to participate. And there was also really good representation of multi-specialty and hospital-based or hospital-owned primary care systems. So some really good broad interest in participating in the model. So that said, let's move forward one slide. This is not to say that all 44 applicants are absolutely, definitely in and participating. They have a chance to learn more about what this means, to learn more about the model, about the specifics. And it's really in April when they will make their first decision about signing a participation agreement to be in that Medicare portion of the demonstration. Also, I should note, and as we talked about, providers have to choose between Making Care Primary or the Medicare Shared Savings Program. They cannot be in both of those. Some of the applicants that did apply to participate in the Medicare model definitely are in MSSP right now. So they have, again, that 6-month period of overlap where they can, sign the participation agreement, but then as they learn more, decide what's best for their practice, make that decision one way or the other. So we're not going to end up with 44 unique entities participating or all 437 of those sites. But really great initial interest and showing demand for this kind of activity in the state of Washington to support advanced primary care. So just a couple of other little timeline and milestone items that we wanted to keep you aware of. In mid-February is the first opportunity for the payers to signal their intention to participate in this, to continue those conversations with CMS and with the providers that they're interested in aligning with this model. CMMI has put out some pretty broad guidelines about what alignment with their payment model looks like. And that is what the payers will be signing on to, that they, agree that they're aiming for those areas of alignment. They want to continue the discussions. And then in the summer, August of 2024 is when they'll submit more detail to CMS about what that looks like for their plan, what kind of alternative payment model they'll be using that aligns with Making Care Primary principles and approaches. So this is the general timeline for Making Care Primary. We just want to make sure to keep you updated, given that this is such a great opportunity to bring some of those CMS dollars and alignment opportunity. And some of what you all are going to talk about today is really maximizing that multi-payer alignment potential to ease burden for providers, but move everybody in this direction towards more prospective, care coordinated oriented payment models. So let me pause here and see if there's any questions about either the timeline on Making Care Primary or the applicants for the Medicare portion of the model. Great. And I also want to give Judy an opportunity just to share any more thoughts about either the provider applicants that we saw or our ongoing conversations with payers and providers about this opportunity.
Yes, thanks, Kaylee. I just think I am super thrilled with the number of practices and systems that applied. I think it really shows sort of whatever audience we look at, whether that's the legislature, whether that's payers, whether that's purchasers, that practices are really interested in this, and they're really interested in doing something different and getting support. And so, so I think that's all great, and I look forward to figuring out how it shakes out. So I guess if there's not anything else, I'll move on. So I'm going to present on prioritized policies and strategies to reach the 12% expenditure target. And to sort of frame this question or frame what we're going to do a little bit. Oh, and excellent. There's a slide on framing it. So we've done the first two tasks as a committee, and we have this third task to go that's to recommend methods to the legislature to incentivize achievement of the 12% target. And that includes recommending specific practices and methods of reimbursement. And so based on the polling that we did before, on some of the presentations we've had and the conversations we've had in this committee, we have pulled together, I think it's it's either 7 or 8 different strategies that are our recommended methods. And so I'm going to walk through those today. We can have a little bit of discussion, but for each one of those things, we're going to have a deeper dive. And so over the next few meetings, we'll see how long it takes us, but for the next few meetings, we'll have conversation on those. This meeting, we're going to have 2 presentations about workforce. And so we'll start that deeper dive into that one. And after we do the deeper dive, then we'll vote on each of those individual recommendations. So that's sort of the cadence for what's going to happen. So with that, next slide. As you remember, these are organized by 4 key domains that influence primary care expenditures. And so some of that will be categorized in here. So direct investment, paying more. Capacity growth, which is both workforce that we're going to talk about today and reducing barriers to spending time on patient care. Administrative simplification, I guess, is another way to say that. Patient behavior, increasing patients' use of primary care services, and reduced expenditure on other services because there's improved primary care access. Next. So when we were talking about this internally and pulling together what we as a committee have talked about, we decided that these policy recommendations should adhere to the following principles. So first, there is a very clear linkage between the policy and achieving the 12% expenditure target. That there are clearly defined action and actors, so we know what to do. The policies are financially, operationally, and politically feasible. And the policies result in improved access and quality, not just expenditure. We want the whole banana. So with that, we will move to our recommendations. So I'll just go through these, and if there's high-level questions, we can talk about it. Otherwise, as I mentioned before, we're gonna dive into each of these and have more conversation. So recommendation number 1 is that legislation be passed to mandate commercial and public players increase their annual primary care expenditure as a percentage of total by 1 percentage point annually until they get to 12%. Also, as a part of that, the Office of the Insurance Commissioner is evaluating ways to leverage existing authority to require carriers to report primary care spending when they do their annual rate reviews. Second is increased Medicaid reimbursement for primary care. So determine the amount of funding needed to increase reimbursement for primary care practices and services covered by Medicaid, with the goal of getting to a reimbursement level of no less than 100% of Medicare. The policy implementation may be incremental based on available funding at the state level, but should target getting primary care reimbursement rates to 100% of Medicare. Recommendation number 3 is about multi-payer alignment. So the committee supports the multi-payer collaboratives work in aligning standards, quality metrics, practice supports, and payment models. And that the collaborative is going to align the primary care transformation model with the federal Making Care Primary model that we just talked about. And that the legislature will advance multi-payer primary care alignment efforts, particularly for state-funded plans to participate in a Making Care Primary aligned transformation model. Number 4 is about patient engagement. So a statement of support for payer and purchaser or employer education and incentives to promote creating a relationship with primary care and accessing preventative services. And then support for public health agencies, specific efforts to include primary care engagement in public education. Number 5 is workforce development. So prioritize funding for state primary care workforce initiatives as collaboratively identified through the Health Workforce Council. And since those initiatives are, oops, go back one more. Since those initiatives are already done, that's part of why we're going to start with number 5. And then those first 5 we've talked about, and staff recommend these 2 additional options, which are based on policies adopted by other states. So number 6 is following the 2024 reporting of primary care expenditures by HCP land categories, the committee may make recommendations to the cost board for the portion of primary care expenditure that should be tied to alternative payment methodologies for expenditures to count towards that expenditure growth target. So not just spending on primary care, but really moving into value-based models, which aligns with Making Care Primary. And then number 7 is that the cost board should identify primary care expenditure targets that are based on a per capita expenditure instead of an aggregate expenditure ratio of 12%. And this is based on both Oregon and Rhode Island moving towards this type of measurement that they think more holistically gets primary care to more people. So these are the 7, all in one place. And I invite questions or comments at a high level if people have them. Cheryl?
Yeah. Hey, everybody. Here's so one, I love this thank you for the summary. It was fabulous. It's great to see it all on one page, and I'm generally quite supportive of all of them. Here's my worry, and you won't be surprised to hear me say this. I don't know if it's fast enough. So I will tell you, our network has had 3 practices purchased in the past year, and cost will now be more, right? And the care won't be as good. They were acquired by systems. They now have facility fee associated with them to go see them. That's a cost. That's a new cost right there. It's not going to be as close to home. And if we don't do something really soon, all the independent practices I represent are going to have the same fate sooner rather than later. And I just worry this isn't fast enough. And Making Care Primary doesn't account for kids at all yet. And I don't see any plan on when it will. And so I'm just very worried about not these tactics and that these are wrong or off track, just the speed at which we can attain it.
That makes sense. Yeah, thanks. DC?
Hi, Judy, thanks. Are we going to be going over details of 6 and 7 in the meeting as it unfolds? Because I understand the concepts, but I'm having trouble thinking of what the kind of net effect of those differences actually is or would be.
Yes, so we're not going to talk about them today,
Okay.
But we're gonna have, and I don't know, we're still working at exactly what the cadence is, if we do 2 of these or 3 of these per meeting.
Okay.
But we'll present you with a lot of detail about what that means. We'll probably, I think the hope is to have sort of a white paper to summarize like what this means, and then we can talk about that. And for sure, that'll include the kids. I think talking about the speed for number 1 is also a worthwhile thing to sort of talk about, how quickly we'll do this, or I don't know, maybe even number 2, I don't know, maybe all of them. But yes, that's the plan.
I would also just add that I share Cheryl's sentiments in terms of pace. I can't speak to the PEDS part, of course, but the landscape is changing pretty quickly. And acquisitions are happening in the full spectrum of primary care as well.
Yes. Jonathan?
Hi, yes, love this. My comments about number 4 are probably more so for the future. I think preventive services is a pretty broad term, and so when we do take a deeper dive, I would love for us to take a specific dive as to what we mean by preventive services.
Oh, that's a great call out. Yes. We can add that to our list.
Jonathan, do you have any ideas of what that might look like? Sorry, just chime me in, because I think that's the topic for the next meeting that we're currently planning on. Do you have, maybe I can ask you this after the meeting, but do you have any thoughts on that particular, how you go about looking at that particular piece? Oh, I think you might be on mute.
Sorry about that. We're how many years into Zoom, and I'm still doing this on mute.
Every time, I swear, myself included.
In the earlier slide, correct me if I'm wrong, I may have seen parentheses like health fairs or things like that, which seem more like events than a service. Whereas things like USPSTF, United States Preventative Service Task Force, grade A, grade B preventive service recommendations to me might be more specific. And then, of course, there are other sort of screening and preventive services recommendations from other organizations, and it might be good to sort of drill down. Do we mean gatherings that can facilitate? And then thank you so much, Cheryl. Bright Futures for Pediatrics as well is incredibly helpful for pediatric preventive services. And so I really love that those events might be, and those vehicles might be ways to engage people in preventive services, but engaging with sort of the Bright Futures recommendations and or USPSTF recommendations and or any other recommendations that might exist might help outline exactly what we want to encourage.
That's really helpful. That adds some additional clarity to me as to what you were thinking. Thank you.
Great. So we have our work cut out for us in the next few meetings, however long that takes. And we are ahead of schedule, but I see that Bianca's on. So I'd like to welcome Dr. Bianca Frogner, who's professor and director of the University of Washington Center for Health Workforce Studies. And the following 2 presentations on workforce will enable us to consider creating recommendations that support those existing workforce recommendations that we will, I think, talk about at the next meeting. But this will give us, I think, a lot of background to get there. So Bianca?
Thank you so much for having me today. It's such a pleasure to see this group. So I will certainly run through a number of slides here, but hopefully there'll be time for discussion. So today I was invited to talk a little bit about primary care workforce and think about the workforce development piece and how that relates back to the primary care spending benchmark. And really, I think today hopefully this is just a start of our conversation because this is a fairly big topic. So maybe I'll help to set some baseline information and give a bit of a framework for some of the thinking that this committee might do on these topics. But before I go, I do want to make sure I just acknowledge a few things, including some disclosures. So maybe I'll just go to the next slide. I think, yeah, thank you. So I am currently an appointed member on the Washington State Healthcare Cost Transparency Board. So I do recognize that whatever you say is going to come back to the board. So I have more my hat on as the academician today, just sharing what I know. That being said, it's certainly also important to acknowledge that I am employed as a faculty member in the Department of Family Medicine at University of Washington. And I did want to just disclose various funders, including to myself and the Center for Health Workforce Studies, including the Washington State Legislature, state contracts from the Washington State Workforce Training and Education Board, as well as several others. And I just want to make sure folks are aware of that. But there are the usual disclosures, which is that anything I say and do not represent the views or opinions of any of my funders. So we can go up to the next slide. Some of you may be familiar with the Center for Health Workforce Studies, or CHOOSE for short. I did want to just give a little bit brief background if you're not familiar. CHOOSE is an independent research center that is housed in the Department of Family Medicine at UW. It has been in the department for over 25 years. I do direct this center, and I have been there for about 9 years now. Our team includes both faculty members and full-time research staff who are spanning a number of disciplines, including medicine, but also nursing, pharmacy, public health, dentistry, et cetera. So we in the center focus on a broad spectrum of healthcare workers, and a lot of our work is national in focus, but we also do a number of state analyses. And you'll see some of the findings from studies that we have done both at the national and federal level as I speak today. And generally, our goal is to try to inform folks like yourself who are thinking about these issues around the health workforce. And a lot of times we do think a lot about issues very deeply about career pathway development, thinking about ways that we can diversify our workforce, and thinking about effective ways to recruit and retain our workers. So a lot of my perspectives do come and are informed by the work that we do at the center. And certainly I'm not alone in doing this work. And so this is just a nice pictorial graph of all the people who I am fortunate to work with. So next slide. And a big part of our funding portfolio does come from HRSA, although it's somewhat being outsized by some state work that we're doing, which is fantastic. But I do want to just alert to you that there are these federally funded health workforce research centers that exist around the country. Each center has a theme. Our themes within the portfolios of work we have at CHOOSE are focused on the allied health workforce, which is a term that the federal government has used to basically allow us to look at workers beyond health, physicians, nurses, and dentists, and look at everybody else. So we kind of look at the hodgepodge of workers, but we also have a health equity portfolio, meaning that we think about how healthcare workers address issues of health equity. But our colleagues across the country have focused on areas of long-term care. They focus on issues of behavioral health, oral health, public health. And if you want to learn more about what these centers are up to and what they're thinking about, the Health Workforce Technical Assistance Center that sits out of SUNY Albany is particularly a useful place to start. And I will note, probably most importantly, that there is no primary care workforce research center that exists as funded through this program out of HRSA. And our program out of HRSA sits out of the Bureau of Health Workforce, specifically the National Center for Health Workforce Analysis. That is not to say that there aren't folks who do workforce and have research centers on the primary care workforce. There are folks at the AAMC, the Association for American Medical Colleges, who do their own health workforce research around the physician workforce. There are the Robert Graham Center, which is coming out of AAFP, and I always get the A's confused. I think, and John can probably correct me, I think it's the American Academy of Family Physicians. Yes, okay, I got that right. I should know this. So I do just want to note that there are others who are even more specialized in specific areas around primary care, including the physician workforce, where the Robert Graham Center is probably the leading group in particular who thinks about the primary care workforce with a focus on family medicine and primary care at physicians. Okay, so let's go to the next slide. So what I hope to accomplish today is I hope to give you a little bit of a framework to connect the health workforce to health spending, at least as I tend to think about it. And just a little bit of background, I have a PhD in public health and health economics, so I'm not a physician myself. So I do come with this with a little bit more of an economic lens. I will give you a brief overview of what we know about the Washington State primary care workforce, and I'll then focus more of my comments around the challenges facing the workforce as a way to think about recommendations for future primary care workforce development. Let's go ahead to the next slide. Yeah, you want okay, there we go. So this is a real brief pictorial view of kind of what the goal is, right? At least for the Cost Transparency Board, our hope is to bend that cost curve. And that does have implications for labor growth. It usually means that there's some slowdown in the labor force growth or the wage rate. But I would say that historically, wage rates have been pretty steadily growing upwards. And so, and usually reducing wages is not a popular option. So we might end up seeing more of a reduction in labor. So next slide. So when it comes to increasing primary care spend, I mean, you all know this, but the hope is that we capture more of that pie. But that does mean then either we're capturing more of the labor force or we're paying them more, or some combination of the two. So that's just, I think, useful to keep in mind. So moving to the next slide. So a slightly different perspective of this. So you have labor and you have wages, and those are just two parts of the supply side of the spending model, right? So from when you think about healthcare spending, whether it be primary care spending or total spending, from a supply perspective, it is the number of things, including people, times how much those people or things cost. And for workers, it's wages. So again, you can either increase labor or you increase wages, or both, and that's how you get yourself to higher spending, including in primary care. But I think a lot of times how most of probably the conversations have gone, both probably in your committee here, as well as the Healthcare Cost Transparency Board's perspective, is that we think a lot more about the outputs, meaning the number of services provided and how much we're being reimbursed for those services, right? And we're hoping that we either get higher reimbursement for services or that we're producing more services. So I just want to note that those production of more services or the prices of them, they do translate back to the people who are being paid to do those services. And we're trying to figure out how to translate their wages. So it's just, there's no right answer in terms of which one of these parts of the puzzle we're trying to address, but it is important to know that if you're increasing reimbursement or cutting reimbursement, that does translate to somebody's wages, or it means that you reduce the number of people that work, or vice versa. So this is just a basic framework from which I tend to operate with. In it quickly, you can see how complicated it can get in terms of what recommendation and which lever you're trying to move. So let's go ahead to the next slide. So I'm going to try to situate my next several slides by giving you some sense of what how to think about who's in the workforce. I tend to like to provide a slide kind of similar to this, but there are in the United States about 17 million people who work in healthcare. And if you look at how they're distributed across different settings, there is no setting in the national data that is called primary care, but we do call, you can roughly say we have ambulatory care as a rough proxy for primary care. And in the United States, broadly, that 17 million people get divided up such that about 35 to 45% of people work in ambulatory care settings. Now, the difference in that number is whether or not you want to include home health care or not. For those who are really nerdy about codes and how the industries are kind of classified in the United States, home health is actually technically an ambulatory care setting. I oftentimes think of it more as a long-term care setting because that's where a lot more long-term care services are provided. So if you don't include that, then ambulatory care is about 35% of that pie. I found some data here within Washington State out of oh gosh, my brain is kind of blanky at the moment. I found it through our labor department that produces and pushes it forward to the Department of Labor, to the Bureau of Labor Statistics. And I found that if I use these same classifications, which includes home health care, Washington State is employing 53% of people in the ambulatory care environment. So we actually seem like we have a fairly large ambulatory care group within Washington State. And just to give you a sense of 17 million people in the United States, that's the denominator of this pie. For Washington State, it would be 3.2 million. So that means there's about 1.7 or so million people working in ambulatory care in Washington State. And this is not capturing people who might be working in, say, retail pharmacies or, retail centers like urgent, those walk-in clinics. So those kinds of places are not included in this pie. Okay, I'll go to the next slide. So another way to break up those same 17 million people is to look at what occupations make up that 17 million people. When you look across all these settings, a lot of our focus tends to be on the physicians and the advanced practice registered nurses or PAs or the RNs, which in totality is about 20% of the pie. That means there's another 80% of people who do something else and are employed to do something else in ambulatory care. Now, I decided to focus this pie a little bit more on the occupations within the ambulatory care sector, so that 35% of that earlier pie that I showed. And in ambulatory care, we have a slightly higher percentage of physicians working in this sector, slightly more APRNs and PAs, which is not so surprising, but we have fewer RNs, because many more RNs tend to be employed in hospitals. So that's not so surprising. It's not as big of a group. I didn't put the number here because I didn't have it immediately available to me, but about 7.1%, so that same number as the RN group, are medical assistants. And that's a fairly sizable group as a single occupation within this pie. It is worth noting that if you break down ambulatory care further and look just at offices of physicians, that is one of the bigger employers of medical assistants, and that's closer to 15% of that pie if you were to break it down. So just to give you a sense that medical assistants are a fairly large single occupational group within the ambulatory care sector, which is a little bit different when you talk about the broader healthcare environment where RNs is the single largest occupational group when you look at it broadly. So I do really want to note this because I'm going to keep coming back to medical assistants over and over again. And I want you to kind of understand why I'm coming to this. Now, one of the recommendations I'll later come to are some data challenges. I am not able to replicate the same pie for Washington State because what I don't have access to is a breakdown of occupation by industry so that I can parse out the specific occupations by these different sectors. Now, it is possible that data do exist with the Employment Security Department, ESD, so that's the acronym I was looking for earlier, but that data are not easily publicly available as far as I can find. So let's go to the next slide. So to better understand what clinicians are doing in the state of Washington, we oftentimes have to turn to things like licensure data. And for non-licensed workers, we have to turn to surveys. So I'm going to show you a few snapshots from surveys and analysis of licensure data that our center has done in partnership with other organizations like the WWAMI Area Health Education Center and other groups within the state. And these snapshots these studies have been done over time on an ad hoc basis. For the most part, we are approached as a Center for Health Workforce Studies to help analyze some of this data. And so we try to produce reports every few years to give you a snapshot for state leaders like yourself to understand the state of our workforce. But it is somewhat time intensive to figure out and unpack all the issues around each of these different kinds of workers that we have employed in healthcare. And so I'm going to just pick a few and just highlight a few numbers, but there's a lot of material in these reports that I highly recommend and that folks check out. I do provide a link, I think, within each one of these slides too, if people want to go and find them sooner, or you can just go to our website and search for these. So I want to just start with the Washington State physician workforce. So let's go to the next slide. And I'm kind of picking and choosing some numbers I'm choosing to have here. So in Washington State, we had about 18,000 physicians working in direct care within Washington State in 2021. When we looked at this compared to US numbers, it does look like in 2021, we had fewer physicians per capita. That also meant when you looked at primary care physicians, we also seem to have fewer primary care physicians per capita compared to the United States. So I think that's an interesting point by itself, is saying, is there an opportunity to increase the number of physicians per capita so we're closer to the US average? About 1/3 of all Washington state physicians work in a primary care setting. So that includes your family medicine docs, your general internal medicine, and general pediatrics. That's part of that pie, but you can see that breakdown a little bit more on the right-hand side. About half of our primary care physicians are family medicine providers. So that is kind of worth noting, is that family medicine is certainly kind of that pipeline. Now, I know that many of your other meetings that you have had, when I look back at your agendas, had been focused very much on the physician workforce, and understandably, that is kind of the billable provider from which you can probably have the most amount of data on. So I'm going to move on now to some of our other clinicians that I know haven't been as much of a focus, in part because I know it can be sometimes difficult to find data associated with what they do. But I'll start with the next one on advanced registered nurse practitioners. Or I guess in our state, we call them ARNPs. Other folks tend to call it APRN. So apologies, I will kind of switch between these two acronyms. So let's go to the next slide, please. So similarly, we did a study in 2019 looking at ARNPs. So let's go to the next one. And one too many. Okay, there we go. Okay, so can you go back one? Oh, go back, one more. Oh, no. You're going forward. You're thinking you go back. Wrong direction. Two more, I think. There we go. Okay. Oh, almost. No, you're going the wrong direction. It's slide number 14 that I'm trying to get to. I think you need to go 3 more back. Nope, wrong direction. Okay, let's go 1 more forward. Okay, there we go. Okay, so we have about 6,000, almost 7,000 NPs employed in nursing. And here I don't have a national comparison, because one of the challenges is that we're using 2 sources of records to identify the number of ARNPs. And so to do this nationally would take additional work, but it is, I'll come back to some of those numbers again a little bit later. But so we have, I think it's just worth noting that of our NPs, we have 93% employed in nursing. So just because you have a license doesn't necessarily mean you're practicing. Kind of, I didn't have a similar number to compare for the physicians, but it's just worth noting that it's not, a head count by itself is not always sufficient, or a licensure count is not always sufficient. You need to figure out how many are actually working. It is interesting to note that about 3/4 of them actually practice, so who are licensed in Washington state are actually practicing in Washington state. So that means that there's another 25% who are working in some other state, meaning that they might have a license somewhere else. It could be that they're licensed, or that they could be working on a border state, things like that could be happening. All right, let's go to the next slide. When we looked at ambulatory care setting and including community health, about 40% of NPs are employed in primary care. So one of the points of what I'm doing here is to give you a sense of like just, and you already know this, is that a pure count either by, these national numbers, or whether you're doing it by licensure data. One of the challenges is trying to pinpoint how many workers are actually available and doing the work in the area, in the service and delivery area that is of interest. So in our case, it's primary care. And it just takes a couple levels down to think about, well, how many are licensed? How many actually are working directly in care? How many are working in our state? And then how many are working within the setting in which you're doing? So there's several cuts you have to get to before we get to a number. Okay, let's go to the next one. So we did something similar for the RN workforce. It was in that same time period because we had access to the same data. So let's move to the next slide. So for RNs, slightly fewer of percentage of the RNs compared to the ARNPs are employed in nursing, but you'll notice that we have many more RNs. You have some 90,000 RNs. I noticed that I did a typo here on the left-hand side. 2/3 of the 90,000 RNs are practicing in Washington state. So many more are either practicing somewhere else in another state. So they might be dual licensed in multiple states. Okay, let's go down to the next slide. And of the RNs, as I kind of alluded to earlier, and this is now Washington State versus what I showed you earlier was for the national picture. Only 17% of our RNs are employed in ambulatory care or community health. And that's because hospitals are definitely a large employer of our RN workforce. So let's go to the next one. So we did something similar for MAs, and our state is the only state that actually licensed medical assistants. So we specifically focused on medical assistant certified MACs in this study. We are one of 4 states that, at least I think last that we counted, that require a certificate. But this is a workforce that, as a result of us doing licensure, we can actually do some tracking of this workforce, which is not possible for many of our other assistant kind of level jobs, is that we don't have databases like licensure data to track how many workers we have. And we are fortunate to even have this ability in Washington State that we can do this kind of work. Now, there are MARs, medical assistant registered, who might be counted as an MA, but they don't have the title of a medical assistant as recognized by the state. So they may be working as a nursing assistant, or maybe their employer have some exceptions. So it's just also worth noting that when we talk about medical assistants, especially if we compare to national numbers, that we have to make sure that we're really talking about apples to apples, because MAs are a fairly broadly defined occupation nationally. So let's go to the next slide. So among the
May I
MA
ask you a really quick point of clarification on that, Bianca?
Sure, yeah.
Okay, so I'm knee deep in a medical assistant certification right now. You can be an MAR or MAC, but you still have to have a license with the state.
To practice as a medical assistant, yes, correct.
Right? So is
Yes.
this both of those?
So this is
Are they-
just the MAC. So this only is MACs. We only went to those who had an MAC. If they were not licensed and they said they're MAR, they are not included in the data that we were looking
But
at in this particular study.
Okay, but you missed out, we missed a whole bunch of MAs then, because we do have that data, correct? Because they
Yes.
have to have a
Yes, so the numbers.
license. I know it
Yeah.
gets confusing, the certificate
know.
versus the license, but
No, exactly. And I see Renee is also adding. So in this particular study, so I didn't have a number that I was able to put out right away for the slide. So we had 15,000, almost 16,000 MACs in 2017. And there were 7,500 or so MARs without a license that were not included in this data. So you're right. That is a significant chunk of people. And so and that's actually, I would say, presenting an opportunity for us to think about how can we make sure that we are including these MARs, get them licensed so that we can use them effectively in primary care. And so when it comes to, at least, so this was based on survey respondents, because this is where we get some more information about our MAs, is really through the surveys, where we can better understand who they are and what they do. The licensure information is somewhat limited. We did find that a higher percentage of them are being employed in the state of Washington State compared to RNs, but most of them work in ambulatory care. So I didn't quite summarize all the numbers exactly, but if you want to do all the math, roughly we have about 10,000 MDs and MPs who are working in primary care. And then we have about 15 to 16,000 RNs and about 15 to 16,000 MACs working in primary care. So certainly more RNs and more MAs than the MDs and MPs, but and it's just about 50% more of each one of them. So and this is really the bulk of who is really delivering primary care are these 4 occupations. I do recognize I do not have physician assistants on here, and that's just not data I had easily available. Okay, so let's go to the next slide. So as I mentioned before, when we think about labor, or when we think about the supply side of spending, there's the people and the counts. So we have some rough numbers, although many of them are points in time numbers right now of what we have in the primary care workforce. And so the wages side of things, I tried to see what kind of data I could find. And from the national perspective, I just put pulled out a select number of wages for the occupations, most of the occupations that I mentioned above. And I broke it out for those in offices of physicians, those in outpatient care centers, which is the two major sectors of the ambulatory care sector. And then compared that to all settings that includes hospitals and long-term care. And so, you know, hospitals certainly skew some of the data a little bit, especially for, it tends to be for, well, okay, I would say for the physicians in particular, if anyone's practicing in hospitals, but or RNs, and actually in some ways the data weren't not nearly as high as I expected. But all that to say is that what I'm looking at the median wage, because averages can be skewed by some outliers. So I try to look at the median, and you can see that those who were employed in outpatient care centers do generally get paid a little bit more than those working in physician offices. And physician offices can also be nurse-led practices. It's just the title that's kind of given to that category. And then for Washington State to use as a comparison, I again can't compare wages by specific settings. So I looked at Washington State of wages for these professions across all settings, and that's why you have the third column of data of U.S. all settings, just so you can have a benchmark. And you can see that generally in Washington State we pay well relative to the national average. And I know that might not seem like it might. To me, it actually didn't sit at a gut level very clearly as right, but I think one of the challenges is that when you look at the entire United States, we're including all kinds of states with all kinds of different costs of living. Perhaps the right comparison might be California or Texas, or or sorry, California or Washington D.C. or other places with high costs of living. So I think that's just worth noting too, the challenges of trying to compare wages, and that I again can't drill it down to specific location. Okay, let's go to the next slide. So as I kind of alluded to earlier, I mean, and what I didn't really tell you right now is whether or not we have the right or the wrong number. And I saw a comment kind of come through, is this question of like, we might have some some standards for how many primary care providers we need for adults and kids. And I think to some degree, yes, there's certainly recommendations for that. What we don't have good numbers for is like, what's the right number of NPs, RNs, MAs, or anyone else in the team? And I would say that's not, there's probably no one right answer to that question. And one of the challenges, and certainly from work that I had done with colleagues at George Washington University looking at federally qualified health centers, is that, you know, the reality is in some communities, they just cannot recruit very well for some of these professions. It's very difficult to bring them out there. So if you set a benchmark that says some community that has long struggled to have, say, primary care physicians, and they must have X number of physicians per capita, it's good to be aspirational towards that. However, in the meantime, we have to figure out how places might make do with the providers they have available. And that we have seen that those communities that have struggled to, say, recruit certain kinds of providers still manage to provide high quality care with the providers that they have. But we need to better understand and unpack kind of what different teams might look like in different communities, figure out when we set numbers about what we expect, what's aspirational versus where we are now. And I know that's always been a challenge, even thinking about primary care spending. And like, I was on the BREE collaborative, actually, that probably should have been a disclosure too, in terms of thinking about some of those definitions, is that we long debated about whether or not the definition should be based on kind of where we are today, or should it be aspirational, and it ended up being a little bit of both. And I think that's the same thing when we talk about the workforce. And we have the current situation of what our workforce looks like today. And the question is, where are we trying to go? And if we're trying to get to a world where we're trying to increase our spending to 12% of the pie versus where we are now, which is about, depending on the number we're using, 5.5. I mean, we're talking about potentially doubling the number of people, or doubling their wages, or some combination of the two. And you have to think about, how are we going to double the workforce? As many of you know, increasing the supply of the physician workforce is not as simple as just saying, tomorrow I want a new primary care doc. It does take a long time to set the pathways all right. All right, so I was just saying, so some ways in which we're going to address this question of how are we going to increase the workforce to kind of get us to 12%. So it's either we create more people, which can be difficult. We can try to retain the workers that we have and make sure we don't lose people. So that's certainly a step forward. We can try to expand workers and get them into new roles. And so try to figure out how to do more with the current people that we have. But then we also have to address some broader societal barriers that are going to be important for us to make sure that we kind of get the right people included in the workforce. So this is just a snapshot of a framework that I created with a group of authors where we were focused on the nursing workforce with hospitals in mind, but this framework was really meant to be broadly applied for any occupation in any healthcare setting. And the idea is really that when we think about the workforce and how to get more people to do stuff, is that you have to think about the inflows and the outflows, and then where we really recommend people to focus on is actually the current workers in place right now, and how do we make sure that we support them, because that's really where the bulk of the numbers are. Because every year we are training new people, every year we lose some people. And that's always going to exist. And the entry point and the exit points, the rate is just relatively low compared to the total number of people working. So whatever we can do to kind of plug up the leakiness in the work environment, the better off we are. And these ideas on what we can do to help retain our workforce are not new ideas, and they are cross-cutting across multiple settings. And so there's nothing new necessarily that I'm going to present here in terms of how we think about these issues. But again, hopefully these are frameworks for folks to think about kind of what do we know, or where can we go, and what kind of things can we think about when it comes to workforce development. Okay, I'll go to the next slide. I think ambulatory care in particular is kind of an interesting place to think about, or primary care is an interesting place to think about what it means to grow this workforce, because these are some national numbers I've been kind of tracking over time since the start of the pandemic, where the flat red line there is illustrating the level of employment right at the beginning of the pandemic, right before the pandemic started in January of 2020. And I've just been looking and tracking employment across different sectors up until as far as I got with September, but it's still continuing upwards generally for most of these sectors. And you know, the main point here is to look at the top green and purple lines. Those are your offices of physicians, and then other ambulatory care environments, and that they have been recovering quite well since the start of the pandemic. They certainly experienced this sharp drop, especially dental offices. That's kind of falling in the other ambulatory care setting, and they've recovered and bounced back. And they have been growing fairly consistently. And just as a comparator point, you have that black dotted line or dashed line. That is employment in all other private sectors, not just healthcare. So, and ambulatory care has generally been growing faster than the rest of the economy. But offices of physician is slightly lagging relative to other ambulatory care environments. And this, again, doesn't break it down by primary care specifically versus specialty care. So those are data points I don't have that I can show here. But it is worth noting that ambulatory care generally has been doing fairly well as a sector nationally. And I think it's worth thinking about whether or not there's an opportunity to do something like this in Washington State too, to better track kind of trends over time. And especially as primary care spending might increase, can we monitor something similarly for the primary care workforce in Washington State and do some kind of tracking like this? Okay, let's go to the next slide. So you'll hear me talk a lot about medical assistants, I think, in the next couple slides, in part because this is a study I had done with a colleague looking at turnover of workers since before the pandemic, and then the first 9 months of the pandemic, and then another 9 to 10 months after that of the pandemic. And we were trying to get a sense of who were we losing in the workforce. And I'm just going to show a couple slides here from that study. And one is that the idea of trying to retain the workforce really comes to the fore when you look at who are we losing and where do we tend to lose the most. And it's really the aides and assistants where we have been losing a lot of workers even since before the pandemic. Their level of turnover has always been higher than most other kinds of workers, and they have been slower to recover since the peak of the pandemic. Now, I will say turnover here is a very conservative definition. This is not thinking about turnover as it relates to going to other employers, so the numbers are probably even higher. This is really about losing workers to a state of unemployment or leaving the labor force, meaning that these are possible workers that we should be capturing to keep them in the workforce so that they can actually do the work rather than losing them to another employer, which is certainly important. But it's really trying to figure out where do we have potentially capacity to draw on workers without training a whole new pipeline. And what was interesting in this time period is that we didn't see high levels of turnover among RNs. It could be that at a national level, it just gets washed out in terms of what's happening in different environments. It could be also that we weren't looking out long enough. But it's, if anything, what we certainly have learned over time is that concerns about turnover really, especially that as it bubbles up for RNs and physicians, is that a lot of times it is a symptom and I would say a canary in the coal mine for the fact that other people on the team are leaving them with a lot more work that is probably below their scope of practice and that should be taken on by somebody else. And so this is where we have to think about if we're going to increase the capacity of RNs or physicians, APRNs, that we have to look at what are they actually doing, and is it work that should be actually allocated, delegated to somebody like a medical assistant who could take on this work within their scope of practice. And it's difficult to do that if you don't have a stable medical assistant workforce, for example. So I think that is key, is that we cannot get people to do more things unless we make sure that they are really able to practice at the top of their license. Okay, so let's go to the next slide. And there are some characteristics of the workforce, and this is not unique to healthcare, is that certainly women have been hurt in terms of the COVID pandemic. And then people with children, both men and women, they experienced higher levels of turnover since before the pandemic. But this is actually a trend that had been existing since before the pandemic too, is that women have been generally turning over more, and people with children have been turning over more. So especially young children. And so this starts to set me up into thinking about what are some potential ways that we need to support our workforce. So let's go to the next slide. So I'm going to share some findings from something called the Washington State Health Workforce Sentinel Network. Some of you may be familiar with it. Some of you may have even provided responses to this survey. This is a joint venture with the Workforce Board, and this is something we've been doing for several years now, where we have been, the Center for Health Workforce Studies team of the Sentinel Network has been surveying employers of multiple healthcare employers across the state to understand where are healthcare facilities struggling in terms of retention, recruitment, and long-term vacancies. And we're trying to understand what have they been trying to do to actually address these issues. So these are our people in the state of Washington who are grappling with these real life issues of trying to figure out how to develop our workforce. So I'm going to share some findings that came out of this that were also reflected in a recent Health Workforce Council report. The Health Workforce Council is out of the Workforce Board. Renee Fullerton will be talking a little bit more about that group after me. So let's go to the next slide. So from the Sentinel Network, when we've been tracking these different settings over time, we have been asking where have they been seeing exceptionally long vacancies? And similar to what we saw in national trends around high levels of turnover among assistants and aides broadly, we see that come out in this kind of data from the Sentinel Network, where every round for the last few years in primary care medical clinics, medical assistants has been the #1 occupation where there has been a significant amount of turnover. Now, physicians and RNs are also #2, but it is notable how consistent the medical assistant workforce has been at the top. So let's go to the next one. And we asked, and we have been producing these reports by different settings. So these are just some selected ambulatory care settings or primary care settings as kind of defined by, that have been kind of used by this group. So we have the Washington Rural Health Clinics, medical assistants, again, top of that list. And then let's go to the next one. Community health centers. Now, medical assistants are top of the list, but it's worth noting that they're not consistently so, and that in federally qualified health centers, They are not struggling as much with their long vacancies with medical assistants. They have been struggling more with getting an RN workforce and the physician workforce. So what this tells me also is that there's not necessarily a one-size-fits-all solution for workforce development in terms of one occupation. Medical assistance certainly is at the top, but different settings probably have different needs and different challenges when it comes to figuring out how to recruit and retain their workforce. So let's go to the next slide. Oh, too many. Oh, be back. Back. Oh, one more forward. Okay. So then we asked what were some of the things that might be affecting their ability to recruit and retain staff. And these were 4 categories that we kind of pulled out of this report. And it is worth noting that childcare is kind of one of the top issues there, where about 60% of our respondents said occasionally or frequently or always they were struggling with childcare as an issue. Housing was a next issue, followed by transportation and then workforce violence. So let's go to the next slide. So just digging down a little bit further, we looked at this by different settings. And childcare, when it came to the different ambulatory care environments of community health centers, primary care clinics, and rural health clinics, childcare was an important recruitment and retention factor for the community health and the rural clinics. And a little bit less so for the primary medical clinics. And this probably has a lot to do with kind of resources available to the community health centers and the rural health clinics. Let's go to the next slide. For housing, that was also a more of a top issue for community health clinics and rural health clinics rather than primary care medical clinics. And then let's go to the next one. Transportation was more of a challenge for community health centers, a little bit less of a concern for rural health clinics, and a little bit less so for primary medical clinics. And some of this has to do with location. Some of it has to do with location relative to where people are choosing to live and can afford to live, which gets me to the next slide about housing. Oh, sorry, did I not have a housing one? Oh, okay. Well, housing certainly is an issue, and it's associated certainly with issues around transportation. Now, when we ask about what strategies people are using to actually address these, I mean, so if you hear that childcare is an issue, housing is an issue, these are things that the employers themselves have been trying to address. The community health centers have been saying that they've been trying to increase the child care workforce. They are noting that maybe they need to find some dependent care spending accounts so that people can actually take care of their dependent care needs. Primary care clinics have been saying that they notice that transportation is an issue, so they're trying to provide incentives for carpooling. In rural health clinics, they notice that housing is an issue, so they're trying to figure out how to provide 6 months of secured permanent housing, and as well as recognizing that childcare is a priority. And primary care clinics identify the need for competitive wage plans, and wages is certainly one element to think about how to increase the pay for workers, but try and figure out how to put money back into the pockets of workers by helping to subsidize costs such as transportation and childcare. It has monetary value, and that there may be other mechanisms other than figure out how to pay people more that we can leverage as a society to go and work with the state or go work with federal leaders to figure out how to find those kinds of subsidies and support our workers so that they can be available, not lose their jobs, and be a workforce available to us. All right, so let's go to the next slide. Okay, there are many more things I wanted to be able to say. This was, I'm limited in terms of the data I'm able to provide for giving you a full perspective of the primary care workforce. But I hope this at least gives you some framework for thinking about all the kinds of workers that are employed in primary care. And you can start to see some of the challenges in trying to connect the dots and do comparisons, both within Washington State with other states and with the United States generally. You can see some of the challenges comparing across different settings. We have a tough time actually connecting the dots between what it means to have this workforce, like how many we have and how we pay them, and connect it back to the total healthcare spending numbers or primary care spending numbers. And it's difficult to ask ourselves, what more can we do with the current workforce? I think we can certainly nibble around the edges to try to make sure that people are billing the most appropriate billed services. that they're providing the best kind of care. But many of our providers, especially primary care physicians, primary care nursing, nurse practitioners, feel burnt out already. They feel like they're being asked to do a lot. So we have to figure out, where do we have the excess capacity to increase this? And some of it may be more people. Some of it may be saying, are people doing the right kinds of activities? Where are the administrative tasks that we need to reduce that burden? And who could take it on instead? As I mentioned at the very beginning, there are a lot of other kinds of people in non-direct care roles I did not talk about, who live in that administrative and billing world. How can we kind of reduce their activity so that maybe some of the admin and tasks that are being taken on by healthcare providers should be shifted over there? And then I didn't even get a chance to talk about all the different environments in which primary care is delivered, and the considerations of those workforce, or the fact that we're trying to move towards a place that we do more integration of care with the oral health workforce and behavioral health workforce, and even the public health workforce, and what it means in terms of trying to figure out the right allocation of work as it relates to those groups. We certainly know and have done a number of studies on the behavioral health workforce in the state of Washington, and we know we're a bit in a crisis there in terms of making sure we have enough people there. So if we ask our primary care clinicians to do more around behavioral health, we have to make sure that they have a workforce that's complementary to them, that can also be there to take on the patients if we're going to bring them on. And then there are just these social demographic trends that are happening within the workforce that I didn't even get to, about the changing demographics of the workforce, right? In terms of also wanting to make sure we have a diverse workforce. And we don't have enough diversity at those higher level jobs like physicians and nurses. We have a lot of diversity actually within our medical assistant and other assistant and aide kind of roles. So we need to figure out, how do we make sure that that diversity kind of sticks throughout the entire spectrum? Because we do know that a diverse workforce can lead to better quality care, because you have more chance for concordance between a patient and provider, that a patient might feel like, oh, okay, this person understands me, and that they may find themselves adhering to care better. They may feel more comfortable sharing their concerns with them. So I didn't even get to go into some of that, is looking at the actual demographics of the workforce. And so then here I'll go ahead and kind of end my slides with this next one, which is some recommended directions. And this is difficult because, I mean, this is an area that I spent a lot of time thinking about, and there is no one right step forward. But I do think we need to figure out how to invest in better data collection, do some more investment in the analysis to track some changes of the workforce over time. And that we do need to, while I understand that the goal when we think about primary care spending is focused a lot on the billable providers, we do also need to figure out how to keep track of all the other people working in primary care. And it probably needs to even go beyond those who are working as MDs, MPs, PAs, and RNs and MAs, that we also need to track other people who might be part of the healthcare primary care team, including pharmacists and behavioral health providers. I would say that if we're going to pick kind of workforce development issues, that the prioritization be on retention issues and figure out how to keep the workers that we have. I think generally in the field of health workforce research, feel that this is where we have the bigger bang for the buck. So that means things like trying to think about career pathways, as well as giving people opportunities to develop and grow in their current job, making sure that we know how to support their everyday needs like childcare and housing, and issues that might go beyond kind of what they're doing in their everyday work. So giving them a chance to really be a whole person. If we are going to focus on recruitment, I think that thinking about ways to do more on-the-job training, so we don't lose people to going back to school, is also important. And so apprenticeships certainly also offer that model. So with that, I know I covered a lot of material, probably went over my time, but I know we also were ahead, but I'm happy to answer any questions. Yeah, DC Dugdale.
Hi, DC Dugdale, UW Medicine. Thank you so much for the presentation. One thought that was in my mind as you were talking, and I don't know if you looked at this at all, is that I believe, and I think there's literature on this, so there's considerable controversy as well, that some of the care we provide is probably not necessary. We know some of it's low value, and we also know that, I think we know that there are opportunities for self-care by patients rather than seeking care through a health system. So when we talk about insufficient workforce to do the work, did you consider, or did you even run across any information about eliminating certain work that's currently done because it actually doesn't improve anybody's health or the health of the population. And you know, that's probably a half-day symposium in itself, but can you comment on it briefly?
Yeah, I know. It's a great question. And I think, you know, what you point a little bit to is a challenge that that many of us in the health workforce research arena struggle with, is trying to figure out the what are people doing part of it. And I think where we do certainly have more data on is that there are physicians and advanced practice registered nurses or PAs doing tasks that are kind of below their scope of work, let alone, that's where we know more about, is that maybe people are not doing the things that are best suited for the kind of skills that they have. When it comes to the actual like tasks that might be not recommended care, like we're trying to reduce the amount of imaging services that we have, for example, or, you know, that I think tends to emerge kind of by condition. We don't have like a broad view of kind of what percentage of time is someone spending on those low valued services. I know there are a number of researchers trying to answer some of those questions. I would certainly recommend that you bring in some folks who might be doing some of that work, and I can certainly give some recommendations of speakers to that effect. I do think a lot of what we think about is, and what we tend to know more about is, where are there opportunities for workers to do more with what they're trained to do? And one area I'll say where we've done some work on is looking at MAs and their role in telehealth, and that there are a lot of opportunities to train up MAs to help with rooming of patients, preparing patients online, so that the RNs and the physicians aren't spending their time messing around with a patient, trying to get them to get on Zoom, get them on, you know, there. That's not a great use of their time.
Great, thank you.
Yeah.
I just want to acknowledge there's some comments in the chat
yeah.
that won't be connected. So, so Ginny wrote that FYI for folks, the cost of a middle quality daycare is about $25,000 a year in her experience. And Renee, who's going to talk next, said that she's always struck by how female the younger physician workforce is, and that it will likely have different needs than when there was a male majority physician workforce. And Maddie said, according to ARNPs United of Washington, the count for ARNPs is now 14,000, so almost twice the count in 2023 from 2019. So that's some fun facts. But then there is a question from Cheryl. Is there clear data on the quality and cost of care for each provider type, like ARNP, PA, MD, and a similar question for outpatient practices supported by RNs versus MAs, that sort of thing?
There is a good body of literature at this point in time comparing ARNP and MDs, especially in primary care, in terms of a number of factors, whether it be the number of services delivered, the quality of care delivered, cost of care delivered. And generally, it has been found that ARNPs and MDs in primary care are offering similar levels of quality of care. They are offering similar levels of services. There is a slightly different service mix of ARNPs versus MDs, oftentimes, that are aligned with what their scopes of practices are, and that ARNPs, as we currently reimburse them, is that they are lower costs of care. So as long as ARNPs are delivering the same kinds of care as physicians at a lower reimbursement rate, they are going to be a lower cost provider. That could change if ARNPs do get higher paid, higher reimbursement for their services. And then in terms of RNs versus MAs, we don't have nearly as much information actually there at all. And it is certainly worth thinking a little bit more about that. And some of the challenges do have to come with data. We have to do surveys at this point in time to really understand what MAs do or RNs do. We don't, a lot of times these studies that have arrived around looking at ARNPs versus MDs has really relied a lot on claims data. And we don't have that same kind of data for other providers. And, if I can just mention on that childcare one, that $25,000, I certainly can appreciate that that's a high number. And just putting it relative to the data that I put earlier, that MAs in Washington State as a median get paid $22.82 an hour. That's about $45,000. So that's more than half of their salary, and that doesn't even account for taxes, right? I mean, it is a significant chunk of change that we're asking people to do, and keeping in mind that, and I didn't go as much into the demographics, but to Renee's point, much of our workforce in healthcare are women. Where we see the lowest representation of women are among our physicians, but it's getting better and it's certainly growing. But there are realities that in our society, the burden of childcare still largely falls on the woman. And so childcare is a priority issue for our health workforce, and it is costly. And when that leaves women making very difficult decisions about whether or not to stay in the workforce or not. And that is significant and is worth thinking about how much are we losing people just from that issue alone, and trying to figure out how to support them so they can stay in the workforce.
Great. This has been super helpful, Bianca. Is there one last question? We have time for one more, but it's also fine to not. Okay, thank you. And thanks for these recommendations to have us ponder. So next I'd like to introduce Renee Fullerton, who's staff to the Healthcare Workforce Council, who's going to present on workforce development and policy levers for the primary care workforce.
Hello, everyone. Thank you very much for the time and attention today. I'm very excited to interact with your group. Next slide, please. So I am Renee Fullerton. I serve as staff at the Health Workforce Council, which is a group that is supported by the Workforce Board and has convened for more than 20 years. And really the goal is to bring together 24 members with leadership from the educational sector, and ensuring active participation and feedback from the government side, from our labor partners, our professional groups, our educational institutions, our facilities and employers, to see where we can find common ground and make suggestions for how to help support the workforce in the state. We are policy development advisory group. Nothing that we do is binding, but we work together to create recommendations each year and submit an annual report to policymakers. Our most recent one just went forward at the beginning of January, and I cross-linked it to the @Madeline in the chat if you're interested. Recent focus areas have been deep dives on behavioral health, long-term care, and dental workforces, but we also spend a lot of time talking about the professions and facility types that you guys are more concerned with within the primary care space. And then, as Bianca mentioned, we also run the Washington Health Workforce Sentinel Network as a joint project with the UW Center for Health Workforce Studies. And we're excited to get that off the ground starting in 2016, because it really enables us to get more closer to real-time information versus some of what we have from the educational side or the licensure side, where it's always a bit of a lagging indicator. Next slide, please. So I thought I would frame this up for us in that people, when they come to talk to me about the workforce, they're typically coming to talk to me and ask about professions. They're interested in nurses, or they come to talk to me about facility or service types. They're interested in hospital workforce or primary care or behavioral health agencies. But I always like to start the discussion about the health workforce by raising the issue of how interconnected everything is. People will want to know what are professions in greatest need, but this doesn't recognize how care is delivered, and that when a particular part of the system is having a workforce challenge, it very quickly spills over into other parts of the healthcare system. So while we here are concerned with primary care access, when patients can't access primary care, they end up in the emergency department for inappropriate care. And then when a primary care provider is trying to find behavioral health supports or resources for one of their patients and they're not able to do that, they end up having to do the best they can managing a really complex behavioral health patient in a primary care environment, which might not be the best place for that services. And then when long-term care staffing is problematic, it has huge downstream impacts on hospitals. So just sort of to get this idea that, yes, we're all concerned about sort of different sectors, but everything weaves together, and workers themselves aren't separate. They move between these settings all the time. Next slide, please. So in thinking about the different tools that the state has to impact the health workforce, there are a variety of these, and really all of these are needing to play a role when we need to make a large-scale change. Moving any one thing that you see on this list is not necessarily likely to be sufficient for the degree of change that we need to see here within the state for any of the sectors that we're interested in: primary care, behavioral health, services, hospital staffing. It will require action in sort of all of these different policy levers, rather than thinking that any one thing will get us where we need to go on this. Next slide. Two areas that the Health Workforce Council has focused on most recently, and Bianca kind of led me into this as well, is that really we have some foundational needs in this Washington state about good planning data. We're working on an effort to improve the workforce data that we have. It's been a bit of a black box going back 20 years. If you go back to the original 2002 health workforce recommendations from the council, we wanted to know basic things like, what is the race ethnicity of our workforce? Are they practicing? Where are they practicing? And then 20 years later, we still didn't know many of that pieces of information. And then we're also need to spend more time and effort on research and particularly evaluation. When we put forward an intervention at the state level, we need to go back and check, is this working like we think it is, or do we need to adjust what we're doing or try something else entirely? So you'll see this thread kind of throughout, and that's been a main focus of council recommendations most recently. Next slide. So you'll recall Bianca had a summary slide in the middle of her presentation, very similar to this. The sort of this idea that we need to look across a whole range of different interventions because of the scope of what we're trying to do. And so to increase primary care, we need to increase efficiency in the current systems. And so I'm going to take us through a little bit of more further tour through medical assistance, because that's an area we think a lot about, and there are some places where we could do some more work. We also need to be thinking about our future needs. Who is training our future workforce? What types of workers are coming out? And are those students representing the growth in our state? Are they representing the populations that are underrepresented currently in healthcare? Are we making progress towards creating a healthcare workforce that looks like the patient population that they are serving? And the last one is we also have to recognize that doing getting more workers within our current system isn't likely to necessarily get us dramatically different results. So we need to be thinking about new care models, new settings, using professions and workforce in new ways than we perhaps have in the past. Next slide, please. So this is going to be a whirlwind, but feel free to stop me with questions as we go along. So I thought I would start with sort of ideas around improving efficiencies in the existing system. We know from the Sentinel Network data that we've seen clinics are reporting, patients are experiencing long wait times. They call to get an appointment, they can't get in. It leads to a lot of frustration on the patient side, also feels the clinics that feel like they're not able to serve the folks that they have on their patient panels. And one of those key things that really does impact the ability of physicians, ARPs or PAs to get through their patient flow well is having well-trained MACs available on the workforce. And so when you go back and look, this data goes back to 2015, you can see in the dark blue line that we really are on this declining trend with production of our medical assistants certified here within Washington State. And so we need to find more ways to make this role attractive. Now, there are some positives within here. We are seeing greater pickup of apprenticeship programs within the medical assistant profession. In the most recent year, I have data on 2022, almost, I think about 9% of the total output from the educational system was through apprenticeship for medical assistant certified. But we're seeing decreases in production on the community technical college side and the private career school side, and it's not enough to make up the difference so far with apprenticeship. And the other thing we think about with MAs is why are we not turning this out? Part of this, when I talk to my community technical college partners, is that they're soft demand. It's not that they're turning away candidates from their program. The constriction isn't like nursing where they have more qualified candidates than they can take. The programs aren't seeing as strong interest from students as they would want, and sometimes they're not running full cohorts of students going through there. So why are these professions not as attractive as I want them to be? We need to think about how we can make this more attractive, help set up medical assistant to be a pathway that leads you somewhere within healthcare. because unlike nursing, it's not one that's necessarily connected to this well sort of articulated system where you can see a clear path of how you can advance forward as a medical assistant. Next slide. All right, so that was a quick hit of medical assistants. Here I thought I'd take us on a little bit of a tour on this idea of training for our future needs. So compared to medical assistants, the picture on the physician side, MD and DO, is looking more optimistic. You know, we opened a new medical school here within Washington State. We have PNWU, who also increased their output to about 135 students per year. We are objectively graduating more physicians here within Washington State. Now, the question becomes, are we making the difference we want within primary care? And so to find that out, you have to kind of deep dive within what percentage of these students are matching into family medicine. And so the Family Medicine Residency Network was kind enough to provide me some information. And if you look at the percent matching into family medicine, it's pretty stable. Like, it's not really, we're not making big inroads in getting more of these students to convert over and be in family medicine, which is sort of a key part of our primary care workforce, key in rural settings, key in community health center settings, a lot of those places where we really need physicians to go. And so, oh, next slide, please. The other interesting thing that I think is fascinating is, all right, so nationally, what's going on with family medicine residencies generally? Who are our family medicine physicians? And for those of you who follow this closely, it's interesting to look at the orange line, which represents the number of US MD seniors entering the family medicine match. And then the gray line there that crosses over with it this most recent year is the number of USDO students. And so in 2023, for the first time ever, we actually had more DO graduates filling family medicine residency slots nationally than we did US senior MD students, which is just a sea change because we had 21,000 MD graduates versus about 7,700 DO students. And if you look at our numbers here within Washington State, PNWU has been sending about 33% of its graduating DO class to family medicine residency each year, and the percentages are lower for WSU and UW. And then the other piece on our physician workforce and thinking about training for our future needs, it's interesting to consider, are we training the workforce that we need given where our population is growing? We know Latinx population is one of our fastest growing groups here within Washington State. We're already underrepresented. We don't have the number of Latinx physicians that we need to be able to have any sort of population provider concordance, but we're also going to see even more dramatic growth within that population they're projecting into the future. So I just cross-linked there because I don't have time to really do it justice, but there's a good report from the Latino Center for Health at the University of Washington, linked if you have access to these slides, which has some good further food for thought on the ways we need to be growing our workforce and who we're getting into this training system, which takes so long, as Bianca mentioned. Like, it's not a quick dial to turn to get more physicians out. All right, next slide, please. And then just a quick on the adopt new approaches and models. We also need to be thinking about doing things differently as well. If we really want to spend a lot more money and a lot more time, get a lot more primary care done, we need to be thinking about services within schools, services that could be done via telehealth. There's just a whole different range. And then looking at what other states are doing around if pharmacists can help take off, clinical pharmacy can help take some of the load off in the primary care setting. Just what are other things people are doing that allow for that dramatic increase that we want to see, that's going to be really hard by just trying to do more within the existing system that we have built. Next slide. So when I was invited to come talk, I think there was kind of this hope that I had this really well-developed set of recommendations and a plan, and here's what you guys should do or have to in order to help encourage the primary care workforce. I'll just be honest, I don't have that for you because this is work that we are doing ourselves within the Health Workforce Council. But we are trying to make progress on this. So this last year in 2023, we spent a good deal of council's time picking strategic priority areas where we want to lean on. The first one ties back to that health workforce data for better planning and policy. And we actually had some success in legislative session in 2023 with the passage of a House bill that requires all healthcare professionals licensed by Department of Health to provide information about just a really basic set: practice location, race, ethnicity of time of application and renewal. Are they working? And so the hope is in future years, this becomes effective in January of 2025, we'll be able to look at, say, those medical assistant certifieds and be able to tell, okay, they've told us where they're working now, and we know the demographics of this population. Same thing with the osteopathic physicians right now. That one's also been kind of a black box because of survey challenges and getting response rates that will hopefully be improved through implementation and some technological improvements on this bill. Behavioral health, for me, is a tremendous black box because we have a massively growing number of licensees within counseling, social work, and marriage and family therapy. And yet when I talk to the employers, no one can hire these folks. So clearly there's a more complicated picture going on there that we need data to better understand. Then that race ethnicity piece is really key to helping us understand and evaluate, are we making progress towards everyone's goals in theory to create a workforce that represents our state without the ability to see what our workforce actually looks like. There's been no accountability for whether we're actually making progress towards that goal and understanding how we're being successful or not being successful in getting to that place. But we want to continue to follow this work because, of course, just getting a bill passed is not magic. A lot of the hard work comes actually after a bill is passed to make sure implementation goes smoothly, that people have appropriate data access, and that there is ongoing funding for analysis, or else data does have a tendency to just kind of sit if no one is being tasked with looking through it and putting forward reports and analysis of it. Next slide. Our other strategic priority area that we're just under development right now is a specific focus on rural workforce strategies. It is the view of the council that these areas differ in really important ways from underserved urban areas, but often those two are lumped together. You'll hear rural and urban underserved when they're very differently resourced situations. So right now that is sort of focused on a landscape map because there are several different rural focused efforts the legislature has put time and attention towards. So we want to make sure we have all those tracked and are understanding where efforts are not connected, and then elevate rural voices in those conversations. Right, next slide. So in the book of what I would call actual fleshed out policy recommendations, we did put some forward in our 2023 report, which is linked there at the bottom. Our council has focused on educational debt burden in the health workforce over the last 2 years. So the 2023 recommendations are mainly an update and affirmation of recommendations originally made in 2022. The council is a proponent of loaner payment, which has pluses and minuses in my personal opinion. I will say I'm not speaking for the council when I say that. But I think mostly it reflects their frustration on the part of the council members that school costs a lot and we don't seem to be able to influence what the price tag is at the post-secondary level. And so loaner payment at least addresses an immediate need for the existing workforce. But the council is also interested in that evaluation piece. If you look back over the 3 most recent biennium, the state has invested, I believe, about $72 million within the different programs of the Washington Health the Washington Health Corps. But we have these sort of foundational questions of, what happens to those people? Do they stay through their service obligation? Do we get extra time after they stay, or they become established in the community? What's the ultimate sort of return on investment for the significant amount of money that's going directly into loaner payment? And then we are also involved in a joint effort with Office of Financial Management and Office of Student Loan Advocate to help increase information availability and assistance for the huge part of the healthcare workforce that is eligible for relief under the Public Service Loan Forgiveness Program. We've already had about $1.1 billion forgiven in Washington State for folks accessing these programs. There's been a big push on the public sector side to make this available, but everyone working in 501c3 land also qualifies for this, but has a lot of difficulty navigating the program. And then flavored to match along with Bianca's information about the impact of what we call sort of community resources that enable employment. So access to childcare, affordable housing, and transportation. The council is recommending action on those more just to raise voice and awareness to the conversation than making sort of specific recommendations of legislature should do this, because there are entirely separate conversations going on in those particular spaces. But we like to draw attention to how it is impacting the healthcare workforce. So that was about 60-mile-an-hour tour of the Health Workforce Council. I am happy to get as deeply into the weeds as you would like, or if anything is of particular interest, just let me know. And available for questions. I think that's my last slide that I have. Yeah, DC, Dugdale?
Hi, thanks. So Renee, so the loan forgiveness, what is do your data, or do you have information that suggests, like, if a loan forgiveness program were created today, what's the time to effect with respect to workforce magnification? Do you know? Is that measured in months or still measured in years?
So loan repayment, more typically from the perspective of the council, is intended to help retain current workforce and influence practice decisions. So say you have a physician who's trying to choose between a rural practice and say a more urban practice, and the rural practice offers a loan repayment benefit. It's intended to help sway the decision towards certain practice locations over others, traditionally as a workforce tool. Evidence of kind of an upfront effect is not as strong because it's not a guarantee. You know, if you're thinking about as a medical student taking in all that debt, you don't know on the end of that pipeline that you're going to be funded through a loan repayment program or not. Like currently, the state loan repayment program is able to award about half of the folks who apply in any given year. So if you're looking at like an upfront barrier, there's a little more, and Bianca might have some stuff on this as well. There's more evidence around decreasing upfront cost barriers. And not necessarily even tuition either. When someone goes to school, there's this whole group of costs associated with that. And if folks are coming from lower resource families, they may not even be willing to take out the loans either.
Right. Okay, great, thank you.
Any other questions? Okay. Well then, thank you so much to Renee Fullerton and to Bianca Frogner for their really outstanding presentations today. Oh, and there's comments in the chat from Bianca that read, Renee's last point is particularly important for some of these workers where cost of schooling is prohibitive, and then also including more than tuition, but other costs like books, childcare while going to school, transportation to school, etc. Thank you very much for those comments. Thank you both so much for your presentations. I at least learned a ton, and I think really broadened the scope of the way I think about these issues. So thank you both so much. And thank you all for your participation in today's discussion. The recording and summary of this meeting will be posted shortly on the website. And our next meeting will be on February 29th. So this is how you're all learning that this is indeed a leap year. Looking forward to seeing you all then. Take care.